I'm Optom Yashika Oswal. I'm doing my fellowship in low vision aids from Indian Academy of Optometry. Before you start, when you are faced with a person with a poor vision, it is important to check that everything possible has been done to improve their vision, and they really do need a low vision service. Once the patient enters a clinic, you have to see their mobility and observe that patient can walk without assistance or he needs assistance to walk by. Observing the client's behavior and his physical status can provide an insight to the severity of the problem. Let's start with the steps of low vision assessment. First, we'll review the medical record thoroughly. Then we'll do the observation. Then we'll go for the interview. Interview will be based on the low vision form that is filled out by patient. Then the visual acuity assessment. We'll do both distance and near acuity assessment. Then the contrast sensitivity. Then we'll go for the assessment of visual field. First, we'll do the confrontation test. If further needed, we'll go for the perimetry. Then we'll do the glare sensitivity, then refraction, then management, last rehabilitation. Has the person diagnosis been confirmed by the optometrist and ophthalmologist? Has all the medical, surgical and optical treatment possibly already given? Has the prognosis for vision has been confirmed by a medical professional? Observations will provide you with insight of how the patient uses visions throughout the day or how they use their other senses to learn. In interview part, we'll assess the low vision form which is filled out by the patient, and we'll have a better understanding of patient's condition and his awareness of the condition he's going through. These are the references how low vision forms looks like. Distance visual acuity assessment. The visual acuity assessment begins with determining the distance acuity of the patients. The procedure involves showing the patients large size of numbers on sheets from a certain distance and asking them to identify them. Optotypes, single letter charts, gratings, and crowded letters of different sizes may be shown to patients alternatively. After distance acuity assessment, we'll go for the near acuity assessment. In this step, the patient identifies or reads a certain typesets of a smaller size from a nearer distance. The distance is accurately recorded. The typeset size is denoted in n units. Reading acuity is the most patient's ability to read a more congested and complex typeset prints from a measured distance. Contrast sensitivity test. Sensitivity to contrast is the ability of the eye to perceive the smallest difference in the luminance. In order to measure the contrast sensitivity, a procedure is used in which the subject compares the luminance of the standardized target with its surroundings. After CS test, we'll go on visual field test. The most commonly done test is confrontation test. It's a screening test. In confrontation, the examiner compares the examinee's visual fields with his or her own visual fields. The confrontation test gives the estimation of visual field losses in different quadrants. Today I'll be presenting my case. My patient is a 30-year-old man, manager by occupation. He's diagnosed with choroiditis 10 years back. Now he is referred to a low vision clear clinic for further management. Present complaints: onset 10 years, distance vision, difficulty in seeing faces beyond 2 meters on weaving steps, near vision, difficulty in managing accounts, phone numbers, ADL, the activities of daily living was independent and had no light sensitive problems. Visual problems, spotting bills, receipt currency, writing task. The patient in this case have moderate visual impairment secondary to uveitis. Distance vision unaided. Right eye 1/30, left eye 3/24, both eye 3/24. Near vision unaided. Right eye N64 at 38 cm, left eye N32 at 38 cm, both eye N32 at 38 cm. After visual acuity, we did a refraction, that is retinoscopy. Findings were in right eye plus 0.5 minus 3.5 into 180 axis, in left eye minus 0.5 minus 2 at 180 axis. After that, we did a subjective refraction, that is OD, minus 3.5 into 180 axis. The vision was 1 by 24. In left eye, minus 1, minus 1.5 into 180 axis, the vision was 318. For near vision, we gave plus 4 for the right eye. Patient read N50, that too read partially at 25 centimeter. For left eye, we gave plus 4. Patient read N35, 25. Now the management part. We'll go for trial for the near vision. A required near visual acuity, that is N6, for the currency spotting. Now calculated magnification. EVP is equal to 32 by 12 into 100 by 38. Approx, that is 7 diopter or 1.75x. Need spotting is N6. Calculated magnification. EVP is equal to 32 by 12 into 100 by 38. That is 21 diopter or 5.26x. We did a trial, first trial, plus 7 we gave, patient read N16 and patient was able to see self-written text, recognize currency and mobile numbers at the distance of 14 centimeter. Half eyes, plus 8, patient read N12 but not comfortable. In trial 2, we gave 5x pocket magnifier, patient read N6 and he was able to spot bills and receipts. So in the final prescription, we told patient to change his single vision glasses, then prescribed plus 6 near vision glass for the writing, then 5x pocket magnifier. After near and distance vision test, we did a color vision. The patient was unable to match any colors on D15 test. In Amsler, right eye is deferred, left eye does not report any scotoma. In confrontation, both eye was no scotoma detected. Some other advices were given. First, the patient was reassured about his closer working distance. Explained to him that this glass would help him to view his mobile phones. To see faces, he was asked to use magnifiers.